Welcome to this presentation of new Inter-Eye research published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of Inter-Eye assessments. My name is Keefe Johnson from Doctors Manitoba, and I'll be your moderator. This session focuses on the research behind a paper entitled Disparities in Utilization of Psychiatric Services Among Home Care Clients, a tale of two Canadian jurisdictions. We'll begin with a brief presentation from Dr. Jeff Poss. Dr. Poss received his PhD in 2006 from the University of Waterloo, where he was supervised by Dr. John Hurdes. He has an adjunct appointment in the School of Public Health Sciences at the University of Waterloo, and he works as a consultant in health services research from his home in Vancouver. He will be joined by Dr. Janice Keefe and Dr. Laurie Mitchell. Dr. Janice Keefe is professor and chair of family studies and gerontology at the Mount St. Vincent University. She holds the Lena Isabel Jodrey Chair in Gerontology and is director of the Nova Scotia Centre on Aging. Dr. Keefe is an adjunct professor with Dalhousie Medicine and affiliate scientist with the Nova Scotia Health Department. In fall of 2021, Dr. Keefe was named a Fellow of the Canadian Academy of Health Sciences. Her research expertise centers on family friend caregivers, continuing care policies, and rural aging. Dr. Laurie Mitchell has been a researcher with the Winnipeg Regional Health Authority Home Care Program since 2007. Her primary role is to conduct and contribute to research, evaluation, and quality improvement activities to assist with decision-making, service and policy development, and the quality of care in home care and community services. Her main interest is in improving outcomes and care for older adults in the community and supporting successful aging in place. We'll provide a web link to the articles in this special issue at the end of today's webinar. Dr. Poss, I'd like to turn things over to you now for your presentation.
Thank you, Keir. My pleasure to present the paper today. So to kick it off, let's think about mental health and older adults. In Canada, there's an estimated prevalence that is high, as many as 30% of people over the age of 65 have a diagnosis of a mental health illness. And along with that, of course, in our society, we have stigma around mental health conditions, and that's particularly true in older people, which is accentuated by the fact that many believe that it's a normal part of the aging process. So we'll be looking at long-stay home care recipients in which previous research has found that about a quarter or more have been reported to have a mental health diagnosis. And among these individuals, they can face barriers, both tangible, physical barriers, as well as societal barriers in diagnosis and treatment of those mental health conditions. This home care population is one that is, kind of by definition, relies on others for care. They have high levels of medical comorbidities, and they have a significant loss of social connection. Widows and widowers make up a large proportion of home care clients. But the good news is that having received a diagnosis and proper treatment, home care clients, older adults, can expect better outcomes and better quality of life as a result. I'm pleased to present this study, which kind of grew out of a much larger multi-arm study funded by CIHR around pathways of home care clients. We looked at newly admitted, newly assessed home care clients who were age 60 and over at time of entry, and followed them in our available data for up to 4 years' time. The data came from and were grounded in publicly funded home care programs in the Winnipeg Regional Health Authority. So this is the metropolitan area in and around Winnipeg, Manitoba, and the province of Nova Scotia, the entire province. We used 3 equivalent data sources in this analysis that came from both jurisdictions. The grounding one is the Resident Assessment Instrument for Home Care, or the RIHC, which is a comprehensive assessment which is mandated for use in home care in these 2 jurisdictions for adult clients who are expected to be on service at least 60 days. We also use the Discharge Abstract Database, to inform hospitalizations, which gave us some information about mental health diagnoses. And thirdly, we used physician billing and shadow billing records that included the psychiatry elements, but also other diagnoses that other physicians were making, which instructs our understanding of mental health diagnoses. These three data sources were de-identified and linked and then used in the analyses independently in two separate data warehouses. The mental health diagnoses that form the backbone of this work came from all of these three data sources. And it's notable that we excluded Alzheimer's disease specifically or related dementias from this diagnostic list. So a couple of slides of findings, first around the client characteristics, and these tables are in the paper in great detail, but the main finding here is that more than half of the clients in our two cohorts were found to have one or more mental health diagnoses in the period in which we examined. In other words, from that initial home care entry up to 4 years' time. And this number of 53% didn't differ at all between the two cohorts in the two different provinces, which was in itself quite remarkable that the number matched. Among those with a mental health diagnosis, the Nova Scotia clients were generally of more complexity, had higher needs. This was true both for those with and without mental health diagnoses. There's something about the Nova Scotia system and their entry into home care where they look a little more complex at program entry. But the Nova Scotia folks especially had higher levels of depressive symptoms, and as a result were more likely to be receiving medications relating to those symptoms or related conditions. And levels of caregiver distress and nursing home placement risk as measured by the MAPLE score, a standardized risk measure, showed the Nova Scotia folks to be at higher risk of that outcome. And then in addition, those individuals with a mental health diagnosis were different than those without in small ways. They're a little bit younger, they were more likely to use tobacco, and they're more likely to have instability in their conditions. But generally, I would say there were more similarities between those with mental health diagnoses and those without than there were differences. The second major finding is around psychiatry. And this was the main thrust when we discovered this in the preliminary analysis. We wanted to punch this out. The stark difference between the two provinces, the two jurisdictions. So among those, the 53% in both jurisdictions with a mental health diagnosis. In the Winnipeg Regional Health Authority, we found 27% in their home care episode received one or more psychiatry visits, compared to Nova Scotia overall, where it was 7%. And then across Nova Scotia, we further looked by geographic area, and that number broke down to 13% in the Halifax and greater area, 8% in urban areas outside Halifax, and less than 4% in the rural areas of Nova Scotia, despite the fact that client characteristics in those three parts of Nova Scotia were not any different, especially regarding mental health presentations. In addition to the Winnipeg clients also receiving psychiatry service more often in higher numbers, when they did receive it, they received it more intensely. So around 9 visits on average among those receiving it, compared to Nova Scotia, where it was less than 4 visits per served client. And in addition, in Winnipeg, the majority of these recorded psychiatry visits occurred in a hospital setting, while the majority of the visits in Nova Scotia were not. And finally, some implications and discussion. This mental health diagnosis prevalence of greater than 50% is higher than had been previously reported among home care populations. So the additional data sources help to understand this. Now, you always have to keep in mind here that we looked not just at a point in time, we looked over the entire episode of care, which could have been up to 4 years. So we didn't differentiate when that mental health diagnosis was applied, just that it occurred sometime within that episode. And some episodes were quite short as 60 days, and some were as long as 4 years. We wondered about whether the supply of psychiatrists was partly could be used to explain the differences in the likelihood of receipt of psychiatry. But when you look at it on a per capita basis, the two provinces didn't differ in that regard. However, Nova Scotia does have more geriatricians per capita, which may help correct some of that service imbalance that we see. The bigger picture does suggest a broader mental health strategy in home care is very much needed. A challenge is that, of course, home care is a set of services that sits largely outside of the medical model, and psychiatry is, of course, a medical service. The high prevalence of dementia is something else that you want to keep in the back of your mind, and we did spend a little time with this in the paper, that among those with a mental health diagnosis, up to around 40% of these people also have a co-diagnosis of dementia. And it doesn't differ by that much between the two samples. And so oftentimes with dementia come other symptoms or aspects of care for which mental health services may be helpful. And just a couple things of warning, or just to limit the findings. This isn't generalizable necessarily to all home care clients. It was a selected cohort of the most stable, long-stay home care clients who were age 60 and over. And of course, it represented only 2 of the 13 Canadian jurisdictions that provide public home care in this country. Thank you.
Thank you, Jeff, for your presentation. That was very interesting. I'm reflecting on my time in home care as, which was a few years ago as you were presenting, and it resonates with me. I have a few questions for you about the research. I'm wondering, your research showed that the prevalence of mental health diagnoses was high among older adult home care clients and higher than found in the general population in Canada. Could you help us understand why, despite this higher prevalence, visits to a psychiatrist were low by comparison?
Yeah, thanks, Keir. I would say that the numbers that we have, the 27% with a mental health condition seeing psychiatry in Winnipeg and 7% in Nova Scotia, they both seem low. I guess I would couch it in the fact that we don't know what the right proportion is. I don't think you would expect it to be 100%, so there are other avenues of services and diagnoses. In fact, most of the diagnoses that we see apply to this particular sample come from physicians who are mainly general practitioners who are providing that diagnostic information as part of their claims data. So they saw the client and submitted a claim, and a mental health diagnosis was provided. I think what's more interesting and more telling about the findings here is how that rate of psychiatry visits varies. Certainly, the difference between overall between Winnipeg and Nova Scotia. And so you definitely want to take note of the fact that Nova Scotia is so dramatically lower, but also within Nova Scotia, and this mirrors other past research that shows that access to specialized services, any kind of specialized services, including psychiatry, in rural areas or outside the tertiary care centers is more challenging, and that's what we found. So I would say that psychiatry is only one of the factors that goes into producing a good outcome in a mental health presentation, but so I think there's more to be understood about the actual outcomes. So we're just looking at the surface, which is of course the services, but of course it is a main avenue to getting a good diagnosis and ultimately good treatment and a good outcome.
Thanks. And I wonder, given these results and your comments just now, it seems to suggest the need for a mental health strategy within public home care services for those home care clients. How would a mental health strategy benefit older adults, both in the community or even in long-term care?
Yeah, well, clearly that is the case. That and there've been many reports, many studies, national studies that have have made mention of this, and the need for a policy lens or a way to think about interventions for older adults, not just home care clients, but older adults and mental health services. I mean, clearly things like broader education and training, and more public awareness to fight stigma around mental health and older persons. Better diagnosis, early intervention, because ultimately, I guess, so reflecting on that population and what they're at risk of. I mean, clearly, a better outcome means better quality of life, and that's, of course, what we all want for this population. But also understanding that uncontrolled mental health condition is a risk factor for long-term care entry, and that the system operates better when you have the most needy individuals entering nursing home. That if you can identify and intervene and not only make better quality of life, you may be able to allow that individual to age in place longer at home with home care services, and either not require long-term care entry or require it much later.
Thanks. That makes a lot of sense to me. Why don't we bring in Dr. Laurie Mitchell from the Winnipeg Regional Health Authority. And Laurie, I wonder if you could talk a little bit about how the home care program in Winnipeg supports clients with mental health problems.
Sure, Keir. So the Winnipeg Regional Health Authority is the largest health authority in Manitoba. So very large density there, and so there is certainly perhaps more services available there than, as Jeff mentioned, than you maybe would get outside of such large urban centers. Nonetheless, when you take a look at the whole growth of the home care program from its inception, it never really traditionally was meant to be servicing individuals with mental health issues. And so there certainly is a gap in that respect for servicing for those individuals. And so that is changing. But so within the home care program itself, in the WRHA, there are specialty services that individuals can access. So we have, for example, like a health coordination service, and that is specifically an integrated service for individuals who have complex home care needs as well as mental health issues. But it services a small number of individuals, and as you can see from this research, there certainly is greater need than what that small program can service. Another option is there's self and family managed care programs. So if an individual, if their needs could be better met through employment of different types of workers than what we can provide, they do have that option if they have the ability to manage the employment of their own staff, or if a family member can do that, manage it for them, then they have that option, and that works well for someone who maybe needs certain service workers that can help maybe reduce anxiety or responsive behaviors. And then a third option is in special, we have what's called special contracts. And these are individuals, very complex individuals, say, for example, younger populations with acquired brain injury, very challenging behaviors that this can be managed by a home care program. All other options have been exhausted, even looking at long-term care admission. And those individuals go on to these special contracts where it's very intensive and resource intensive to look for options in the community to keep them in the community with 24-hour support supervision. So that's what home care itself does, as well as, can have referrals to other community programs. And I think maybe that's where some of the difference comes up with psychiatric services in WRHA, because there is geriatric mental health teams that home care can refer to. for individuals where geriatric psychiatrists are involved in these teams and can come in and assess individuals and make referrals for care, as well as other sort of health outreach and behavior response programs that are in the community. But as Jeff pointed out, you know, those are a lot of other mental health professionals, not specifically psychiatric services, that are trying to help individuals in the community.
So sounds like there's kind of a complex range of options available in Winnipeg, and you spoke about Winnipeg being the largest health region in Manitoba by population, but the smallest, I think, by area. So I wonder if we think about the rural parts of Manitoba, the northern parts, people living in remote communities, what are some of the important differences in the experiences of persons with mental health concerns in those rural areas compared to in Winnipeg?
Yes, no, very true. So, you know, and we know that when it comes to health services in general, when you're in rural, remote areas, it is difficult to access services, the variety of services, the level of service, like you can in, you know, the urban centers. And we found that when we looked, so in our research, we didn't look outside of Winnipeg, but we did look at sort of that rural urban effect in Nova Scotia. And the findings we had for Nova Scotia, I know would similarly apply in Manitoba, that even though they were presenting with similar characteristics and need, those rural individuals weren't able to access, or were not accessing services to the same extent. And in Manitoba, with our even larger geography, you can well imagine the difficulty in accessing services. And in our research, in our background before, you know, starting the study, we did find that when it comes to especially psychiatric services, there's even more difficulty recruiting and retaining individuals in those kind of professions when it comes to sort of the rural and remote populations and areas. So, and then in Manitoba, you also throw into the wrench there that we've got these very harsh winters. And so, so if you had to travel for your services, there's going to be maybe days on end when you can't travel because of the winter conditions, or someone needing to get to you. And so it can be very isolating on top of that. So when you have that big geography, as well as the kind of climate that can impose additional barriers, you have tremendous access issues.
Great. Why don't we bring Dr. Janice Keefe from Nova Scotia in, and we can hear a little bit about the other jurisdiction included in this study. Of course, Nova Scotia, a province in Eastern Canada. I wonder, Janice, if you could tell us a bit about the home care program there. You heard about Laurie's description of Manitoba. Is it similar? Is it different when it comes to supporting clients with mental health problems in Nova Scotia?
I think there's a fundamental difference that we first need to address just in terms of the structure of home care. So in Winnipeg, the deliverer of the services in home care is also our people who are employed by the Winnipeg Health Authority, whereas in Nova Scotia, we have the assessors, the care coordinators, doing the assessment of need from the Nova Scotia Health Authority, but we contract agencies to deliver the services. So that's an important distinction, I think, to put on the table. I think the other issue is the suggestion that we do have a higher proportion of geriatricians in our province, given that, you know, about 40% of the Nova Scotians with the mental health diagnosis also had Alzheimer's disease and dementia. It may very well be that some of the lack of use of psychiatric services may be explained by inclusion of geriatricians. However, the wide gap is of course very concerning. I think the point about psychiatry services being more of a medical model is very important. This isn't the way home care was evolved in Nova Scotia as well. We certainly have a multitude of different programs in order to be able to support unique cases such as the self-directed care that Lori spoke about in Manitoba. We have programs such as the supportive program for persons with dementia to help support their families, up to $1,000 a month now, to provide services and supports directly for the individual. So most of the home care program has evolved more so, of course, to help people age in place. And I think that's a critical component, but less maybe less integrated in some ways with some of the other medical services, such as with psychiatry. At the same time, we do have 4 zones in our regional health, in our health authority, and each of those zones would have what we call clinical behavioral specialists, who would be consultants to be able to support home care, the home care clients, the home care case, the program, in order to be able to provide some advice around some of those challenging or responsive behaviors that might occur.
Okay. Now, I noted earlier that one of your research interests is around the friends and family caregivers surrounding their clients. And so I wonder, when we think about these informal caregivers, why is it important to think about their mental health in addition to the clients or the care recipients themselves?
Yeah, absolutely. And we do try to use the term family friend caregivers. We've been told by them there's nothing informal about what they do. So I'm just putting it out there because I know the advocacy people will be down at my door knocking again to remind me. Anyway, yes, it's critically important to recognize the challenging, the distress that some of the caregivers who are caring for the home care clients, that their mental health is also critically important. Of course, remember when we used to fly before the pandemic? You put your own mask on first, right? Before you put your mask on for your companion that you're flying with. And that's essentially what we need to do for caregivers. We need to recognize that without them, in many cases, the aging in place of the home care client who wants to stay at home and out of long-term care facilities for as long as possible, that won't happen oftentimes without that support of a family friend caregiver. So yes, their mental health is critically important. We do have some programs to support caregivers in Nova Scotia. I think we're one of the few provinces that have a caregiver benefit that is part of the home care program, where eligible people can receive direct funding to the caregiver to help them provide respite or whatever they need to help support their own, or taking care of their own mental health. As well, of course, both our programs would have respite care as one of the tools in the toolbox for the home care program. Great.
So maybe I'd like to bring Jeff back into this conversation. This has been very interesting, and as you mentioned, this is focused on 2 of 13 jurisdictions in Canada. I wonder, what's the next step for research that needs to be done in this area, Jeff?
Well, I guess the 2 out of 13 suggests there are 11 or so other opportunities to replicate this. Now, not all jurisdictions have the same data, but many of them do. The key thing there would be the physician data, and Lori, nod when you recognize how challenging it was to get that physician data out and in the light of day. So actually the backstory of this paper is it was never really planned. It's sort of like it was a little paper that could, and sometimes having available data can open doors. And it was this kind of psychiatry is this very small piece of the whole medical services piece of data we had. Yet it was one of the more interesting findings to come out. But in terms of next steps, I would like to understand what the actual mechanisms are relating to how psychiatry is accessed. So it's not the kind of service that someone feels depressed and calls up the psychiatrist and gets an appointment the next week. There's a referral process. There's a whole stage that goes on. And so whether it's a primary care referral, the ability to understand how that's happening, where it's happening, whether it's a hospital encounter, either in the emergency department or as an admitted patient, it'd be interesting to know what the mechanisms are for how this the psychiatry that we're seeing in the data, how it actually comes to be.
That makes a lot of sense. Janice, as somebody who works, with the folks on the front line in Nova Scotia and also considering the research, anything to add beyond what Jeff has touched on?
Absolutely. I mean, one of the areas that we have sort of touched on is the whole role of the geriatrician. So I think that's another component that we could investigate with this particular data set. I think the other issue as well is that we had new clients coming on the program between 2011 and 2013. Since that time, we've had over a 4-year period. So in the last few years, particularly the pandemic, and particularly some of the investments that my province is putting into long-term care and home care, and increasing the wages of the workers, the frontline workers, increasing the caregiver benefit, trying to beef up some of the supports in the community. I'd be very curious how that may be impacting on caregiver distress, and how it may be impacting on some of our findings as they would evolve over time. So I'm hoping to collaborate some more with these folks to be able to keep our understanding. It, as has been said, the whole access to linking and being able to obtain these different data sources is a huge investment of time, but it's really worthwhile in the end. It really does tell that integrated or non-integrated story for our provinces.
And I guess another question might be around the actual mental health services available to home care clients. And, Lori, I want to come back to you. You described actually quite a broad range of fairly defined or specific services available in Winnipeg to home care clients. Initially, I was going to say, what should be done to expand the range of services, and maybe there's still potential for that. But I think what I'd like to ask you is what could be done to improve access to mental health services for home care clients in Winnipeg?
Yeah, no, that's a really good question, Keir. So I think part of it starts with the knowledge base amongst home care staff, and Jeff alluded to this a bit as well. So, and we've heard it. I've heard it from getting feedback from staff in the home care program that they need better knowledge and skills to deal with the kind of prevalence, the kind of increase they're seeing amongst home care clients that have mental health issues. And so I think if we were able to provide some core basic education and skills for all staff, the case managers, the direct service staff, I think that would be beneficial, so they would know what to look for, and also what they could do to maybe de-escalate certain behaviors as opposed to perhaps increased behaviors. So some of those basic skills and knowledge, and then what can they do to provide appropriate referrals? So who do they need to talk to? How can they get this individual connected? So I think some of that knowledge base certainly sits firmly within the home care program to better support individuals with mental health issues. But then beyond that, so I did talk about a number of services. but there still is, those services are there, but accessing those services is still difficult. And that would be one of the things to reduce some of those barriers. So for example, I mentioned a couple of geriatric mental health and program assessment teams. And that's great if you meet the criteria, you're age 65 and older, and you have a physician in place and those kinds of things. But that younger population, there's definite gaps for that younger population. So if you're under 65, then there's difficulty in accessing appropriate services, more so. And then if you don't have a physician, if you don't have a physician diagnosis of a mental health condition, that also can restrict access. Well, then you get into that really vicious cycle. So here you have someone you know has issues, but they're not diagnosed, but you can't get them into the program to get the diagnosis. And so, and it keeps going from there. And primary care physicians might feel that they don't have the expertise to give a diagnosis. So it's those kinds of things that, well, there's certainly been a growth. And to Janice's point, the experience in Nova Scotia is, similar in Manitoba, that in the past few years, and that's why it'd be interesting to keep doing an extension, there's been more resources that are becoming available, but has that really improved access for those who really need them in a timely manner.
Great. And Janice, from the Nova Scotia perspective, anything to add that Lori hasn't already mentioned?
I think that Lori's covered a lot of it. I do worry about the findings in our study around that differential. I mean, it's been mentioned around rural versus urban. I just want to bring it up because one of my areas and near and dear to my heart is how do we support people in those smaller communities, in those more remote communities with this service. Just taking them out of their their little community is not the answer. Do we, think about services that are more mobile in nature, that are more of a localized hub, as they try to do with the zones now in Nova Scotia. But getting access, I think Lori's really hit the nail on the head. If you don't have a physician, it kind of starts there. And there's a lot of people in our province who don't have a physician. Another area that's definitely being worked on.
Great. Well, thank you, Janice, and thank you, Lori and Jeff, for taking the time to walk us through your research and share your perspectives on this very important topic. I think I can safely say that we all look forward to future developments in this important area. And I'd like to thank all of you for joining us today for this presentation on Interie's research into mental health and addictions. If you'd like more information on this or related work, please contact us by emailing info@interie.org. That's info@interrai.org. Thank you.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the Interie website at any time to view new presentations on this special issue as they are posted.